Welcome everyone, and thank you very much for joining us. I'd like to begin by acknowledging the country from where we are all joining these discussions. In my case, I pay my respects to the Malakadi people in southern Lutruwita, Tasmania, where I live and work. And I acknowledge elders now and from previous generations and your care for country and communities over millennia. I'd also like to acknowledge all Aboriginal and Torres Strait Islander people joining today and the important role of First Nations communities, health professionals and organisations in advancing health reform, including around scope of practice. Warm thanks to the Australian Society of Medical Imaging and Radiation Therapy, ASMIRT, for sponsoring this event and supporting independent media and public interest journalism. The webinar is part of Croakey's Medicare 40 Years project, the 40th anniversary year of Medicare being a critical opportunity for advancing important health reform discussions, especially with the upcoming federal election. We've already had 2 excellent webinars as part of this project on addressing oral healthcare inequities and improving healthcare in prisons for First Nations people. And a big shout out to everyone joining us. It's lovely to see some familiar faces there, whether you're here in real time or on replay. Your engagement reminds us of the significance of this review. Unleashing the potential of our health workforce is an independent review looking at the available evidence about health professionals' ability to deliver on their full scope of practice in primary care. It aims to identify priority recommendations for systemic reform and implementation by governments, regulators, employers, professional bodies, educators, and professionals. This webinar is very timely. The review is about to enter its 4th phase, preparing a draft final report and an implementation plan, with a final phase of consultation from July to September. The final review report is due to be submitted to the Minister by the end of October. While the issues papers to date highlight the complexities and challenges of reform in this space, they also share some success stories. Aboriginal community-controlled health organisations were frequently raised through consultations as an example of existing best practice, from which the broader primary health system could learn, due to their multidisciplinary and whole-of-person approach to delivering primary health care. This webinar will inform related journalism at Croakey, live tweeting and an in-depth report by Croakey editor and journalist Mari McInerney. Please join the conversation at the hashtags Scope of Practice, Croakey Live and Medicare 40 Years. We encourage you to put comments and questions in the chat throughout the webinar. We'll be monitoring them for our journalism. Please note the housekeeping details in the chat. If you don't want to be publicly reported, preface your comments by saying this is not for quoting or similar. We will, of course, respect this request, and we ask that any other journalists attending do likewise. Ahead of this webinar, we've published some timely related articles, and you can see the chat for the links. After the event, Jen Morris will provide a written response to the webinar discussions from a health consumer's perspective for Croakey readers. We'll be holding another Croakey Live webinar on scope of practice in August, sponsored by the Australian Physiotherapy Association, so stay tuned for more details about that. And now it is my very great pleasure to introduce our panel. Professor Stephen Duckett, who has held senior healthcare leadership positions in Australia and Canada. He is Honorary Enterprise Professor in the School of Population and Global Health and in the Department of General Practice at the University of Melbourne. We'll also be hearing, of course, from Professor Mark Cormack, who is leading the independent scope of practice review. He works at the ANU College of Health and Medicine and established the ANU's National Centre for Health Workforce Studies. He has previously held many senior roles in governments, including, as I'm sure we're going to hear about, CEO of Health Workforce Australia. Big thanks to Carolyn Hayes, President of ASMIRT, as we know, supporting this and bringing her special interest in orthopaedic imaging, decreasing patient dose and increasing patient care. Carolyn is Paediatric Radiographer at the Royal Children's Hospital in Melbourne and lectures at RMIT. I'm also delighted we'll be hearing from Anthony and Nicholas, the current chair of Allied Health Professions Australia and an appointee on the Strengthening Medicare Task Force. So, Stephen Duckett, the first questions are for you. I'll just have to find the first questions for you. We're hoping you'll set the scene for this discussion and why it matters. Tell us a bit about how long you've been thinking about scope of practice and if you have any success stories to share. And we also want to hear about what are the questions on your mind to help guide this discussion. Over to you.
Thanks, Melissa. And normally I live on the lands of the Kulin Nations in Melbourne, but I'm currently on holidays, so I'm in Europe. So the couple of points to start. First of all, it's important to recognise there are two strands of development that are happening over the last 20 years. The first might be loosely called the health profession strand. The education of health professionals has dramatically improved over the last 30, 40, 50 years. And now health professionals can do much more than they were able to do 20, 30 or 40 years ago. And they've got greater expectations of contributing their skills. And it's really sad if we don't use those skills to their full capacity. The second strand is what might loosely be called the consumer strand. That is, the health system is getting more complex, but also more difficult to access in some sense. There's a significant proportion of the population, a small but significant proportion of the population that don't access care because of reasons of cost or can't access care because of reasons of geography. And so we've got to be saying, we've got to be using all of the skills of the health professions to make sure we can respond to those consumer needs. And those strands come together in this issue of scope of practice. So turning specifically to the question you asked, when I was in Queensland about 20 or so years ago, we were interested in the waiting times for elective procedures, waiting times for outpatient visits. And a group of physiotherapists came to see me and said, we think we can help. And one of the ways we can help is we can reduce the waiting time for an orthopaedic clinic because the rate limiting factor was seeing the orthopaedic surgeon. If a physio and an orthopaedic surgeon work closely together and there is trust between the orthopaedic surgeon and the physio, it is quite reasonable for a person to see the physio first before they see an orthopaedic surgeon, or in fact, instead of an orthopaedic surgeon, and the physio might be able to initiate treatment, non-surgical treatment, which resolves the presenting problem. The person doesn't present to us because they want a procedure, they present because they wanted their pain relieved or whatever. And so we started a number of clinics about physiotherapists across Queensland providing services as part of the orthopaedic team. And a couple of months ago, serendipitously, the person who was managing all of that sent me an article they've written saying, it worked, we've demonstrated it worked, and you should be proud of that legacy of 20 years ago. The sadness is, we started that 20 years ago and it is still not happening everywhere throughout Australia. So we're missing out on all of those skills. People are waiting too long and so on. Thank you.
Thanks very much, Stephen, and especially for giving up some of your holiday to join us. And I'd also just like to acknowledge, I think I saw Professor Jenny May join, and so congratulations to Jenny on her recent appointment. Great to hear from you, and please drop your comments into the chat. And now we will hear from Professor Mark Cormack, who's had a very busy period. If you look at the review website, you'll see the incredible number of consultations and submissions they've been dealing with. So Mark, can you please give us an overview of the key messages that you've taken away from the review so far? If there's been any real surprises for you or not, and any success stories to share, and what about next steps?
Thanks, Melissa, and thank you for the opportunity to talk about the review. And I'm just coming to you today from Ngunnawal and Ngambri country here in the ACT. Look, the review is, as you pointed out, is really kind of getting to the business end of its work, and we are just wrapping up consultation on issues paper number 2. We've had incredible support and input into this. We've had over 1,100 submissions. We've had 31 structured consultation sessions attended by over 700 people. In addition to that, we've had an additional 100 targeted consultation sessions with over 200 organisations and individual groups. And we've also completed a literature and evidence review to, I guess, bring that to the fore in this work. And we reviewed over 1,300 articles to, I guess, come up with the options that are outlined in issues paper number 2. I guess in terms of the key messages and some of the surprises, I think the first thing is I've been both delighted by, but also surprised by the level of emerging consensus that we're seeing, particularly as we outlined the 8 reform options in issues paper number 2. The second, I guess, key message is there's certainly a strong mood for change, and I think Stephen's examples are just one of many where we see incredible innovation happening, resulting in real benefits to patients, a real retention factor for health workers, but we don't really seem to be able to upscale and get through the barriers that are needed for these to become widespread. So I think that's a really important point. The main barriers that we identified, and we looked at barriers across the education and training section. We looked at workplace barriers, legislation and regulation, funding policy and payment systems. I think where we've come down to, there's 2 that really stand out. The payment systems seem to be as significant a barrier as anything really in terms of progressing reforms that enable health professionals to work to their full scope of practice in the primary care setting. There's a strong sense of custom and practice in culture, which seems to work against obvious evidence-based improvements that can be made with incredible benefits, cost benefits, experiential benefits, consumers, and retention benefits for health workers. So I think that was a very key message. The other one is we look very closely at the national regulatory arrangements for health professionals. And generally speaking, we found well supported, and the legislation itself is quite enabling and supporting of full scope of practice. But the issues are twofold that stem from that. Firstly, the NRAS scheme has got a secondary use, which I don't think was really intended. It's become a shorthand for regulatory activity across a number of Commonwealth, state and territory acts. And the second, I think, unintended consequence that we're seeing is this exclusion of the self-regulated professions from access to many government programs where this shorthand approach is used, that certain benefits, schemes and programs are open to the nationally regulated professions, but are not available to the rest. And we think that's a significant shortcoming. It's not the fault of the scheme, it's how it's been misused and applied in many instances to restrict scope. And I guess the other really key surprise, which is why one of our options is this notion of a national skills and capability framework and matrix, is I was surprised at the lack of awareness and understanding of the respective roles and capabilities of the various professions who are trained in the same system, often work in the same system, but a very significant underestimation of the contributions that health professionals can make, particularly in the primary healthcare setting. And that actually did surprise me. And it certainly one of the key areas that we're focused on in issues paper number 2. So I'll just draw breath on that and hand back to you, Melissa.
Thanks very much, Mark. And I do encourage people in the room or Zoom to drop your comments into the chat, because I'm sure a lot of you are working in the spaces that Mark's identifying as important there. So now we'll move to hear from Caroline Hayes. And Caroline, can you tell us why scope of practice matters to you? I mean, to the extent that, you know, we have ASMIRT supporting the webinar tonight, and whether it's as a patient, wearing your professional hat as a radiographer, or as president of ASMIRT. And also we wanted to know what your burning question for Mark Cormack is as well. Thank you.
Thank you. I'm coming from the Wurundjeri country of the Kulin Nation in Melbourne. And yeah, I do wear a few hats, and most health professionals do. So just a few little anecdotes, which will probably explain why I think this is so important to people. As a patient, ongoing hip issue, which I had for over 2 years, working with a physio. Physios can only refer for certain medical imaging procedures, and those that they can't refer for don't attract a Medicare rebate, or a very little one. So my physio nagged me for over 18 months, you need an X-ray and an MRI, we need to find out what's going on. Every time I went to my GP, I went for other reasons, and the chronic pain was just sort of there, didn't worry about it, until I finally remembered to ask for my referral, to find that I actually had advanced arthritis in my hip, and that was why I couldn't climb stairs anymore, and I needed a hip replacement. If my physio had been able to refer me as an allied health professional from her area of expertise, my ongoing pain would have been sorted out 2 years earlier. And I'm sure I'm not the only patient that has that issue. The fact that allied health professionals cannot refer on, and something that came out in one of the reviews I was sitting with the audiologists about how the fact that they can test, but if they feel that you need another test or a referral to an ENT, you have to go back to your GP for that referral rather than just go straight on. So that holds up the patient, it costs them more, and in some cases the patients won't do it. So patient care is being severely restricted. And I sort of look back on myself going, you're an idiot. You work in medical imaging, why didn't you get this done? But that's just the nature of the beast, and I'm not the only one that does it. So as a patient, this reform will be amazing for patient care to be improved. As a radiographer, there's a lot of limits to our scope of practice, and in many ways we're limited by what the radiologist will allow us to do. There are some radiologists who want radiographers, like under national law, if we see something, we're meant to say something. And to us, that means if I see something on an image that is important to the patient's health that needs to be dealt with, I should be speaking to the referring clinician. But there are many radiologists who say, no, you must come to me first and I will speak to the referring clinician. You shouldn't speak to them directly. Now, unofficially, that happens all the time in public hospitals, but in private practice, not necessarily. And again, I think patients are waiting for reports and waiting for results, and they're not happening as quickly as they should do, simply because of that barrier. And even though it's national law, there are, and it's not all the radiologists, don't get me wrong, there are some amazing ones out there that very much are team workers. Radiation therapists, in some places when there has been work done with the radiation oncologists, they can actually treat patients, they plan, they treat, and the radiation oncologist is an overseer rather than I'm the one that does everything. So again, from a patient treatment point of view, far better off if we have increased scope of practice. Talking as president of ASMIRT, we do have an advanced practice award that we give to people that prove, and it's a very strict criteria. We have about a dozen advanced practitioners that have been recognised, but each of them is dependent on their local practice, accepting that they are advanced practitioners, looking at what they've done. And then we've had issues where people have been granted advanced practitioner status. They've proven that they're an expert in a particular field. They change jobs for whatever reason, and they're no longer an advanced practitioner because their new employers don't recognise that their advanced practitioner status. So again, the scope of practice review will actually show that allied health professionals in any profession can do more than their basic training. And just a final thing, allied health has become very, very popular with school leavers, and we have very high enter scores, like in some cases equal to or just below the marks for medicine. So we find that we get a lot of dropout because these really, really bright people are coming into the profession. And after about 5 years or so, they're saying, what's in it for me? What is there new for me to learn? How can I advance myself? And there isn't room for advancement without actually having an advanced scope of practice. And my burning question for Mark is how confident are you that some, I know not all, but some of your outcomes that you find will be accepted by government and funded? And we know that funding is the biggest thing. That's it from me for now.
Thanks so much, Caroline. And now we will hear from Anthony Nicholas. And Anthony, thanks so much for your preview article at Croakey, which made some really important points about what can be done now to encourage advanced practice without waiting for contested national reforms. And you went to some of those issues that Mark was speaking about around cultural change. So can you tell us now why you see scope of practice reform as an equity issue, and also give us an idea of what your burning question is for Mark?
Yeah, indeed. And I just really want to acknowledge also the team at Allied Health Professions Australia who helped with that article, not just me. I normally live on Gadigal land, but I'm also in Ngunnawal here in the ACT at the moment. So for Allied Health, we see scope of practice as an equity issue because the vast majority of Allied Health, they're university trained. They spent 4 or 5 years learning in quite a focused area of practice. They are experts in that area, and they're very patient-centric. It's the nature of Allied Health. It's also, there are 200,000 of them around the country, and about half of them work in primary care in direct-facing roles. So they're very used to working in this space, but what we know is government funding virtually pays nothing for primary allied health. Yes, out of the 2.5 billion, 241 billion that we spend on broader healthcare, 500 million, which sounds like a lot, but is a tiny percentage, is all that goes to all allied health. And how I tend to like to think about that is that's about $20 a person per year in allied health services. So people experience allied health in tertiary care. They realize it's this great benefit to them in care. They go out into primary care and realize the only way you're really going to access allied health is if you can afford to pay for it. And so if we want a primary care system that is focused on consumer and consumer access, we have to think about how every Australian can get access to allied health, not just those who can afford it. And so partly that's an equity issue, really on that cultural piece, on that funding piece. It's that equity around when patients want to seek the expertise of a health practitioner, they are subsidised for some and not subsidised for other. Further, they may be subsidised if they see an allied health practitioner who's employed in general practice, but not the one who's working in a rural local community down the road in their own practice. So there's these disparities around how consumers can access healthcare beyond general practice, and no one's diminishing the vital role of general practice, but we have a sea of health practitioners who can help Australians get healthier, get quicker access to care, and therefore healthier, because all our markers in healthcare are going downhill with the current. So we need to, as we said in the article, the status quo has to change. I think the other things that are really is, I know we're celebrating 40 years of Medicare, and it's only been 20 years since allied health was added. So for the first 20 years of Medicare, there were no MBS items for allied health. And so they were only added 20 years ago, and even still in quite a limited number. So there's that expansion there. But also we can see, we really welcome the unleashing the potential of the health workforce force, because it's touching on many of the issues that most allied health bodies have talked about for 30 years. If you went and looked at a lot of Treasury submissions, most of those have been covered every year for the last 20 years with virtually no movement. And hopefully this is going to be that bit along the line. But there's no one or two big answers. For us, part of that equity is around There are thousands of examples like that. I was seeing my physio, but I couldn't get a direct referral to a specialist, or I could not get a direct referral back to get some additional diagnostic imaging. And so we're in this loop of having to go back and forwards between the general practitioner, and that the fact there's been no investment in getting allied health integrated into the MyHR. So therefore, it's not like there's a conduit of information to be shared. So we've got all these barriers to actually making sure that consumers can get access to the care they need when they need it, and probably the right person as fast as possible to achieve better outcomes for most Australians, because their access is getting worse. Their out-of-pocket is getting higher. Chronic and complex disease is just going through the roof. So, and I suppose my burning question for Mark is also similar. I suppose, does the government and the department have the gumption to realise real reform, not a tinkering, is what's needed if we really want to talk about multidisciplinary primary care for the future? Simple.
Thanks very much, Anthony. And I'd just like to acknowledge that our chair of Croakey Health Media, Professor Bronwyn Fredericks, has just joined us. So really like to give a shout out to Bronwyn, and really to acknowledge that the Medicare 40 Years series arose from discussions of the Croakey board, the directors. So just really acknowledging the importance of our directors. Bronwyn, I don't want to put you on the spot because I know you've just joined, but if you want to leap in and make any comments, just let us know.
No, just it's really great that this has come to fruition now, that having the Croakey live event, and that did come from the board, because it is important discussions regarding Medicare, but also the addition of other aspects like the allied health that I just heard about 20 years ago. I do want to say, you know, unfortunately, people incarcerated at the moment don't have access as well to Medicare or the provisions under that. So there's still areas where it could be improved going forward. That's all. Let's get back to it. It was nice hearing from the speakers. Thank you.
Thanks, Bronwyn. And also to acknowledge Lynn Brodie online as a former director of Croakey, one of our founding directors as well. So now we might move into a more sort of question and answer session. I can't see that everyone has been quite reticent, but we have already got questions for Mark. And I think they're also good questions for Stephen as well, in terms of what will be the political appetite, particularly leading up to a federal election. So how confident are you feeling, Mark, that all this work will actually have some concrete outcomes?
Oh, look, thanks, and thanks for the question. Look, I think the answer to that is I certainly wouldn't put the time and effort into this work if I didn't think it was going to go anywhere. So I think that's probably the first point that I'd make. The second point is that what we've tried to do is in many ways to make government decision-making on such recommendations a little bit easier. And I think the things that governments look for, that they want to see the evidence has been properly considered. And we've certainly done a lot of that. And when we publish our draft final report, it'll be on the basis of very solid evidence. Secondly, the level of engagement that we've had, the breadth and depth of submissions that we've seen from right across the health and care sector, the higher education sector, regulators, etc., gives us a sense that there is a strong consensus on not only on what the problems are, but what some of the solutions may be. So I guess the challenge in putting this to government is to present both the case for change, the level of consensus and support for some concrete actions, and also to draw upon the evidence. So my answer to that is, and certainly the Minister has been incredibly supportive of the work. I've had no restriction whatsoever on saying or doing anything in this space, and I've had a lot of engagement from the department and indeed the state and territory governments. And it's important to remember that even if we just look at these 8 options, and of course there'll be more to say than just the 8 options, only one of them can be resolved through action by the Commonwealth alone. The others require concerted work by the Commonwealth and the states. And I think state and territory governments are very much feeling the brunt of a primary healthcare sector that's struggling, and they are also feeling the brunt of having a workforce that's not being optimally utilised to deliver the care. So I think, I'm confident governments make decisions on a whole range of bases, but we can only deal with the bases that we know and that we've assessed, and I think we've covered them.
Thanks, Mark. You sound more optimistic than I am about governments only taking note of evidence. Stephen, what are your thoughts? What do you think the political appetite will be? I mean, they're obviously complex and quite wide-ranging reforms that have been put forward.
So thanks, Melissa. With Anthony, I was a member of the Strengthening Medicare Task Force, which was chaired by Mark Butler, and I was also a member of the Mental Health Reform Group chaired by Mark Butler. Mark Butler is a reforming minister and absolutely committed to improving Medicare, strengthening Medicare to respond both to the current patient needs, the epidemiology, but also that, the system was run down over the previous government, and including in the first budget, Peter Dutton as Health Minister got rid of Health Workforce Australia. We had an organisation which was trying to lead reform in workforce, and it was abolished, and nothing was heard in that space for a decade. I think just to give you some insight, in both the Strengthening Medicare Task Force and in the Mental Health Reform Group, Mark Butler, as Minister, sits in the meeting all day and chairs the meeting and is an engaged participant. The Strengthening Medicare Task Force report talks about the importance of multidisciplinary care. Butler is totally invested in that. And in my view, his investment is not just about talk, but is going to be about trying to shepherd these reforms through, both in terms of reforms which cost money and in reforms which cost political capital in terms of negotiating with the states, as Mark Cormack pointed out. Mark Cormack is doing this careful preparatory work of the evidence, of the consensus building and so on. And those are going to be preconditions for change and facilitators of change. So obviously, one of the issues is money, especially in the primary care space. So you have to have a funding stream for allied health and nurses to play a greater role in primary care. And My Medicare will provide the framework for that. And so I think it's important. We shouldn't expect to see change overnight because there are big structural reforms that are needed, the legislation and so on. But what is really important is to set the overall direction, to say, this is where we're going. Here, states, this is an agenda. You don't have to go out and redecide everything all over again and delay things. But we've got to actually say, this is where we want to go. And we take the incremental steps each year to actually build the reform. So what the Medicare looks like in 40 years' time is nothing like Medicare looks like today or like Medicare looked like when it was first introduced. So I'm actually an optimist in this area, and I think we will see significant reform because it is so timely for that reform to take place.
Thanks. Thanks very much, Stephen. There is a question for you in the chat, and I guess it's a broader question as well from Philip Herman, which is quite a specific question about saying we've had the evidence for some time about changing how we approach funding to enable allied health to specialist pathways, as we've discussed, but how to achieve the reforms, what do we need to do differently? I guess a question sort of leading on from that a bit is, what can the different organisations in the sector that are wanting to see reform, I mean, they're making consultations and submissions, but what more can they do to help support reform?
So I once worked with a very cynical minister that said when he didn't want anything to happen, he told people to go out and write a petition to Parliament. Now, I'm not saying that funding submissions as part of the Treasury process are of the same kind, but Mark Cormack identified a number of barriers here. One is culture, that the culture of some of our hospitals has ossified. And although there was tremendous change during COVID, during the first 2 years of the COVID pandemic, tremendous change, really rapid things that were happening, a lot of it has sort of dropped back. And so it has been physios bashing their heads against a brick wall within a hospital to try and get change. So I think what the potential of what Mark is doing and the news and the scope of practice review is that it will unleash, it will legitimize a lot of those bashing of heads against the wall. The other thing is you've got to, what we did in Queensland was do it systematically. So it is not just going to happen at Princess Alexandra. This is something that's going to happen right across the country, or right across the state, that we are going to be doing these things in a systematic way and not just relying on trying to change one hospital. We're going to try and build, if it's good enough, to try and reduce the waiting time for people seeing an orthopaedic surgeon, an orthopaedic clinic at PA, it has to be good enough everywhere across the state. So it's trying to legitimise, it's trying to create an authorising environment which makes it easier for each of those changes. I'm not saying they're going to be easy. As I said, the culture in many of these hospitals has completely ossified. The status hierarchies are terrible. But I do think there is an opportunity. We now have an opportunity and, in a sense, an urgency, because waiting times are so bad. The opportunity costs are so high that we ought to be moving quickly.
Thanks, Stephen. Alison Barrett has dropped a question in asking whether you're as optimistic if we have a change of federal government next year. I mean, I know you've noted that state and territory governments have an important role in this space, but I think still a federal government makes a difference by setting the leadership nationally and helping to set the narrative and agenda. So are we too far out from the election to be making predictions?
I think so. And I read quite a good piece by Jack Waterford this morning about Peter Dutton, and we really don't understand what he is really trying to achieve and what sort of government he'd try and lead. And the good news, if there were a change of federal government, then they are going to face some of the same problems as everybody else. They are going to face the rural workforce shortages, for example, and the reality that we just cannot continue to provide services in rural Australia in the way we've provided them in the past. And so we've got to actually do things differently. And so we've got to actually, and a rurally oriented government, as traditionally coalition governments are, will actually face the same issues and probably have to end up following the evidence that has been demonstrated.
Mark, would you like to add anything? Caroline and Anthony as well?
Look, just to agree that irrespective of who's in government, the problems remain the same. And I guess sensible evidence-based reform that's also based on a kind of a consensus of interests, a coalition of interests, is more likely to withstand a change of government than one where there is sort of, violent outbreaks of opposition. So I think if we can continue on that course of trying to address concerns, if there was to be a change of government, then to have the case just as strong, because the problem will not go away without this sort of reform, as Stephen said.
Caroline and Anthony, would either of you like to add?
I just think we need the government reform simply because there's a lot of turf protecting in various places, not just from doctors, but also from some others. And without government reform, this is not going to change. So I agree wholeheartedly with what is happening, and fingers crossed that change of government will be irrelevant because of the work that Mark's put in.
Yeah, I agree. I'm probably less optimistic than Stephen and Mark, and mainly because, of course, we're focusing in primary care. And partly that's because, you know, the last big reform in primary care around multidisciplinary teams was 20 years ago when allied health were first added to MBS, and not a lot has changed since. So I think when we focus on primary care, what we've seen is definitely, I agree. The minister and the department seem to have recently discovered multidisciplinary care with allied health and nurses, and how they can optimize those in care. But so far, most of the reforms have been embedded where those people have to work within a general practice business, not more broadly in primary care, where consumers are accessing them in a whole range of ways. And, you know, My Medicare is a classic example of where it's, you know, contained within the general practice rather than within broader primary care, which I think is really important in outer urban, regional or remote areas where there may be a sustainable allied health businesses surviving there and servicing the community. But My Medicare is basically saying, oh no, you need to employ a new physio in your own clinic, even though there may be one down the road.
There are some questions in the chat sort of relating to these issues about the tension between having general practice-based models versus, as you say, extending more widely, but then the potential for fragmenting care. And Professor Kathy Eager has raised the question, how do we extend scope of practice for nurses and allied health without expanding fee-for-service?
I'm happy to hit on that one. One of the certainly one of the main options that we've identified and we're getting some soundings on, and we've done a lot of background research on, is really not to compound the problems with fee-for-service by adding more individual isolated practitioners to it, but to look at kind of blended, holistic, population-based, risk-adjusted funding arrangements that enable a healthcare organisation, whether it be a practice, a group of practices, a healthcare entity, to have the flexibility to employ whoever they need to employ to meet the needs of their enrolled population. So I think there's certainly a case for expanding funding in primary healthcare, but I think to expand it in a way that just overlays the existing 90-10 split of fee-for-service versus blended payments, I think would be unwise, and it's certainly not something that we would be recommending. We think we need to look at other ways that can encourage team-based care rather than every person getting an individual item for every minute of their time that they spend on a patient. I think there are more creative ways to fund. Even within the hospital environment, you couldn't possibly run a multidisciplinary service in a hospital if every single player within that hospital gets their clip of the ticket for every single item of work they do on a single episode of care. So I think that we certainly need to look at different ways than fee-for-service.
I guess Kathy's made the point there about the role of other, there's often resistance from different medical groups to changing or moving away from fee-for-service, but what about the potential for the non-medical groups to be more coordinated or advocating for different funding models? What does the panel think of that? Do you think there's appetite across the sector, or do you think there is such a strong push for fee-for-service from different professional groups?
I think fee-for-service is quite often used as a, you know, I've sat in meetings where people have talked about greedy allied health wanting those fee-for-service fees, but other sectors being excluded from such criticism. You know, and I think we're talking about funding consumers to get access, not necessarily fee-for-service, but unfortunately most of the blended models are run only through a certain model. So we're still unclear with My Medicare, whether allied health outside of the general practice will be included in a multidisciplinary care arrangement, or whether they'll only be if they're employed within that general practice. The same with other blended models. The departments have talked about other non-fee-for-service models of care for 20 years and virtually developed none. And, you know, I suppose our concern is this will be another great discussion, that this is a path we need to move down. And when a few times their things are trialed and are successful, they decide they're too expensive to run, like the diabetes trial, probably a decade ago now. So I suppose it's you know, I've seen a few comments in there about what do we start doing where we can just start testing stuff in the market to test what works, to start removing those barriers for consumers to get care. And I think it is that central part of that is that how do we properly share information if in a multidisciplinary team with you know, general practitioners, specialists, allied health, nurses, et cetera, where can they share that information so that that coordination of care occurs easily? Because it's not happening now, because most places are still requiring on multiple secure messaging systems, faxes, letters, you know, systems that don't communicate with each other.
Yeah. Yes, there's so many interconnected issues, aren't there? And I think that comes across very clearly in the issues papers as well, the complexity of addressing some of these issues. I've just had a direct message I'll respond to later. So just to think, future cast, where would you like this discussion to be in 5 years' time? Where might we be in 5 years' time? And what are your key calls to action to make that happen? So, you know, you can present your vision, what you think is realistic to achieve in 5 years, which sounds a long time, but it goes past quickly. And as we know, when we look back to, say, the National Health and Hospital Reform Commission, it can take a long time to make change. So 5 years' time, where would you like to be and what's going to get us there? Stephen, would you like to go first?
Thanks, Melissa. I'll just try to think through where I'd like to be in 5 years' time. And if I do it in two components, in the primary care component and in the non-primary care, secondary care component. In primary care, I think Mark Cormack was the one who said that currently about 10% of general practice revenue is blended payments. I think in 5 years' time, I'd like that to be, say, on average, 25%. And that general practice looks very different, much more multidisciplinary than it is now. To take Anthony's point, I think although my view is that I prefer the physio and the whoever to be in the same practice that I go to, I think we also have to acknowledge that that might physically not be possible. And so we've got to think about contracted models and really close relationship models. And I was just talking to someone this morning about a service at Mount Druitt, which is linked to general practice, but a hub that consumers can go to. In the non-primary care world, sorry, I should also say that general practice isn't only general medical practice in my view in the primary care space. So in 5 years' time, significant change in the multidisciplinarity and the recognition of the benefits of multidisciplinarity. In the non-primary care world, I would like to see, the industrial infrastructure, the cultures of hospitals to have changed significantly over this 5 year period, that we will begin to see that the use of physios in orthopaedics, speech pathologists and so on, right throughout the health professions. I mean, taking Carolyn's point, this may be a bit outlandish, but I had a health problem last year. I had a health problem earlier this year. The GP said, I think this is what's wrong with you, but we need to get a scan to verify it. I went along, had an ultrasound. The sonographer looked at it and said, yeah, that's what it is. So I had a GP saying that's what it is. I had a sonographer looking at it saying that's what it is. Why did I need the radiologist to say that's what it is as well? I mean, you know, we've got to actually be saying these people know what they're doing. They're well trained. And so this could happen right throughout the system, and I think it ought to happen right throughout the system.
Thanks. Thanks, Stephen. Anthony, would you like to take us to your future in 5 years' time?
Yeah, I suppose ultimately we know because consumers are getting access to the right practitioners for their healthcare at the right time in a timely way. And I think that's only going to happen if in the future we see that everybody in the healthcare system, practitioners and consumers, are valued for their roles. And that is that cultural shift. But I think it is that matter of thinking of all those examples, just like Carolyn, Stephen and Mark have given. There are 1,000 simple things that if we just remove those barriers, especially with a GP workforce shortage, that there are ways we can get the system to work faster so that people don't constantly have to be loopy-loop around duplicated things with half a dozen people agreeing what's needed next, but somebody has to make a decision and only one person is funded to make that decision.
Thanks, Anthony. Caroline.
Coming back to what Stephen said, yes, I agree wholeheartedly that we don't always need the radiologist to report, and there's lots of other things that radiologists do that are beyond our scope of practice. So in 5 years' time, I'd like to see allied health professionals being used to their full potential. Now, it may take longer than 5 years because sometimes to actually be certified as an advanced practitioner or to prove that you have those advanced skills, you may need to be doing some study, and you may be needing to get a portfolio together or proving certification to prove that you can do what you are doing. But I'd like to see that we're well on the way to that, with expanded roles for all of us in various ways. And not everybody will want to expand, but expansion is the most important thing. And acknowledgement from other professions that health professionals are professionals in their own right and are more than able to do what they do. And just another little example for you. In one hospital I worked in a while ago, the radiology registrars started doing night shift after 6 months of training, but they spent their first 18 months going to the senior radiographer with 20 years of experience saying, what do you think of this? But the report was written by the radiologist, not by the radiographer. And I'm not saying that radiologists shouldn't report, but the UK model clearly shows that radiographers can report and we can do advanced practice, and that's where we should be heading, so that we take off the lower burden and leave the radiologists and the other medical people to do their higher level stuff and leave the low level stuff for us, which is advanced practice for us, if that makes sense. Sorry. We want role expansion. It's going to be better for the patient in the long run. It's going to be quicker. And the other thing in general practice is if we have this role expansion and multidisciplinary teams going, we will stop having patients using emergency departments as their GP clinic because they get a one-stop shop. If they can get that outside in the community easily, rather than having to traipse from one appointment to another, back to their GP, off to an appointment, it will make life so much easier. So if the physio says, go and get your x-ray and then come back to me, that's going to save a patient at least 2 trips to the doctor, one to get their referral, one to get their results. So that's going to stop people coming to emergency for those sort of things. So in the whole run, everybody's health will be improved because access will be improved.
Thanks, Caroline. Mark, where do you think realistically we might be in 5 years' time, given you have more insight than most of us into how governments work?
Well, look, I think what I'd like to be able to see in 5 years' time would be firstly in the primary healthcare sector, that it's been strengthened. That is, we have more people choosing to commence and maintain and keep a career in primary healthcare as opposed to the workforce defaulting to the hospital environment. So I think that's an important thing that we need to do. Secondly, that our funding and payment models actually incentivise outcomes, disincentivise low-value care, and are linked to the need of populations as opposed to the location of health practitioners who dispense that care. I think that's a really important point. I think that we also need to look to a future where the current retention rate of medical practitioners, which is around 95%, is because they are able to work to a full scope of practice and to deliver care right up to their level of training and skill, is also the same level of retention that we've got for nurses and the allied health professions, and certainly the retention rates are significantly lower for those. And I think that we have a digital, the health system finally embraces and catches up with every other industry segment of this economy and uses the digital infrastructure to cut out a lot of the kind of workarounds, the lack of knowledge, the lack of guidance, the mucking around of consumers, and actually revolutionises and supports health professionals to work to their full scope of practice. They're the things that I'd like to see. And finally, Stephen opened with an example of physiotherapists being able to make a big difference. Why does it take 10 years to progress innovative models of care and translate them into customer practice? We've got mechanisms in pharmaceuticals to bring new drugs to the market and into the system. We've got mechanisms in MSAC to bring new treatments into the payment system, but we don't seem to have a repeatable, reliable institutional mechanism to be able to bring advancements in innovation in health workforce practice and models into the mainstream and bring it up to an industrial scale.
Can I just add to that? I think, Mark, your idea of this skills register matrix and so on is, I think, really fundamental, so that, you know, a hospital or someone can certify, I've got these advanced practice skills, so they become portable, and so other hospitals know that that those advanced practice skills exist, because, you know, the imagination of many are not as great as they ought to be.
Thank you both for that. Mark, you're getting some thumbs up for your comments on access to records and IT and so on. I just quickly want to acknowledge, I got a DM from someone and it was meant to go to everyone, so I just want to quickly read it out to you. I'm a physiotherapist frustrated with the slowness of change. For example, I cannot understand why everyone can get an optometry-free eye check each year, but patients need to qualify for a chronic care plan through their GP and often pay a fee for this to get 5 Medicare-assisted physio visits per year, which gives a meagre $58 rebate, and then patients are not happy when you ask them to pay the gap amount, as their GPs are often bulk billed or well rebated. All Australians deserve access to allied health services to improve health outcomes and reduce the chronic burden of costs. So just wanted to acknowledge that, and also acknowledging another comment in there about viewers looking forward to hearing the health consumer perspective on the discussion tonight, which hopefully we will be publishing at Croakey next week. But we will be publishing Murray McInerney's story in time for our Croakey Bulletin this week. So finally, if I could ask everyone to think about what headline they'd like to see on this story. In other words, what's the takeaway that you personally are taking away from this discussion tonight? Something short and snappy. Would you like to drop it into the chat? And I'll ask the panel members to give us their headline, while if anyone online would like to drop it into the chat. So, Anthony, what's your headline? Make it sensational, please. We like sensational.
Minister announces major reforms across the health sector. That's the headline I'm looking for.
Caroline?
Healthcare is from more people. Sorry, let me rephrase that. Healthcare comes from more professionals than just our doctors and nurses.
David.
Big reform is necessary and feasible.
Mark.
Unleash the potential of our health professionals.
Okay. Well, thank you so much, everyone, for joining. It's been terrific to see, you know, the number of people who came along, and I'm really grateful to our panel members. You're all very busy people, except for Stephen Duckett, who's on holidays in France. So thank you for giving up some of your holidays with us. So just really like to show appreciation, and thank you everyone for dropping the headlines into the chat. And a big shout out to ASMIRT for sponsoring this event. It's quite unusual, I guess, for an organisation to be sponsoring journalism this way. And we're really grateful that you were willing to work with us in this way. And please stay in touch, everyone.